Very good morning. My name is Dr. Deepak Marwa. I've been teaching foreign medical graduates for last 13 years. And today I am standing here before you to explain some basic issues related to cardiology, especially heart sounds, which are always asked in the exam. As you are aware, the FMG screening exam has undergone a sea change with respect to clinical questions being asked. So therefore, our objective of listening to this CD or a DVD will primarily to understand that what is the thought process of the national board and what they really want from you when it comes to performance in the exam. So listen to the data carefully, which I speak before you, and we shall be talking about heart sounds. Well, the very first thing that is important to remember in this particular topic would be the sequence of events that ultimately matter for auscultation. How you auscultate is secondary, but theory is more important. So first we concentrate on the theory and then we go to the practical part. If you look at the very first diagram that I'm going to sketch before you, this particular diagram would be representing an event that goes by the name of atrial systole. If you look at this diagram, you can see the fact that the atria are generating force which is pumping blood into the ventricles of the patient. So therefore, this very first diagram that I've drawn here before you would be basically represented as atrial systole. The power of the atria is sending blood into the ventricles. A few milliseconds later, there will be a slight change, and it is the change that I want you to appreciate with respect to the first diagram. The change that I'll be representing here before you will be responsible for generation of the first heart sound, which would be called as mitral and tricuspid valve closure. Now is the turn of the ventricles to contract. The ventricles are generating force at the movement, but if you look at the representation at the movement, you can see that I have shown aortic valve and pulmonic valve to be still closed. The pressure in the ventricles is more, but blood is not going out of the heart. So you can remember this diagram as where no blood comes in the heart and no blood goes out of the heart, and therefore this would be represented as isovolumetric contraction. Now a few milliseconds later, the situation will change again, and now if you concentrate on the third diagram with respect to the second one, I am making a slight modification in this diagram like this. The first change that I am representing here is that the pressure in the ventricles is relatively higher as compared to what was a few milliseconds earlier. At the same time, because the pressure in the ventricles is rising, it is causing opening of aortic and pulmonic valves, and therefore 80 ml blood will be rushing into the aorta and 80 ml blood will be rushing into the pulmonary artery of the patient. Therefore, this particular diagram would be referred to that as ventricular systole. And during the phase of ventricular systole, as you can see, the aortic and the pulmonic valves are opening. So the sound which is produced due to opening of the aortic and the pulmonic valves would be technically called as ejection click. Ejection click would be characterized by aortic and pulmonic valve opening. This particular diagram is responsible for 80 ml blood going into the aorta and 80 ml blood into pulmonary artery, which is basically the stroke volume. And the situation will change again. And if you now have a look at the fourth diagram that I'll make before you, you need to appreciate the changes that I make in the fourth one with respect to the third one. The change that I'll be making here will be number one, the mitral and tricuspid valves have come back to their normal position. The second change that I'll incorporate in this diagram will be that the aortic and pulmonic valves have also closed. And when aortic and pulmonic valves are closing, this closure of the aortic and pulmonic valves will be responsible for generation of the next heart sound, that would be S2. I'm using two separate colors to highlight the fact that the color black is representing the closure of the valves. Second heart sound is going to be aortic and pulmonic valve closure. In this particular stage now, blood will once again start rushing into the atria, but will not be given permission to enter into the ventricles. This would be called as isovolumetric relaxation. This is where the heart is beginning to relax, and then few milliseconds later, in the last diagram, I'll be representing before you complete ventricular relaxation. If you look at the fifth diagram and compare with the fourth one, you can see that in the fourth diagram, blood is coming into the atria but is not being given permission to go into the ventricles. But now there will be free flow blood occurring into the ventricles of the patient, and this particular would be represented as ventricular diastole. If you look at the last diagram now, ventricular diastole, you can see that two valves are opening here. The valves which are opening here are the mitral and the tricuspid valves, and therefore the sound which is produced due to opening of the mitral and the tricuspid valves will be referred to as the opening snap. This opening snap will be characterized by mitral and tricuspid valve opening. So what you can see here in the sequence is that I have drawn 5 diagrams before you, and each of these diagrams are sequentially representing the cardiac events. If I summarize all of this data together, you can see that when you're gonna put the stethoscope on the chest of your patient, you will be able to hear the lub and the dub sounds, that is S1, S2 and S1 again. Right after S1, there is an event happening, and this event is known as ejection click. Right after S2, there is an event happening by the name of opening snap. S1 and S2 deal with closure, whereas ejection click and opening snap, the English word is self-explanatory. Ejection means blood is going out of the heart. Opening snap, the English word is there. Opening means the valves are opening. You just need to remember that ejection click is characterized by aortic and pulmonic valve opening, and opening snap is characterized by mitral and tricuspid valve opening. Therefore, when you will be auscultating your patient, you can hear S1, S2, but in the exam they can ask you the heart sound between S1 and S2, that would be ejection click. Immediately after S2, that would be opening snap. Those of you who have done your internship or are into residency, please do not understand or get an idea of the fact that opening snap here is a normal finding. Loud opening snap is a normal finding. Loud opening snap is abnormal. Loud opening snap is mitral stenosis. A loud ejection click can be heard in patients who are having, for example, aortic stenosis. Our perspective here is to understand that when it comes to heart sounds, the normal heart sounds are gonna be S1, S2. In between these would be ejection click and the opening snap, and then subsequently we have 2 more heart sounds in between that are referred to as S3 and S4. In the exam, you should be able to tell which heart sounds come before S1. Then the heart sound coming before S1 would be answered as S4. Now, obviously, all of us know that S4 is not a normal heart sound. But in an exam, he wants to see whether you know about the cardiac cycle or not. So he will ask you which heart sound is heard before S1. That would be answered as S4. The language or the MCQ that came in your exam was like this. The MCQ in your exam said, which of the following is a pre-systolic heart sound? In this MCQ, he not only evaluated whether you know what comes before S1, but he also wanted to know whether you know what is systole and what is diastole. Systole is going to be period between S1 and S2. Diastole is going to be period between S2 and S1. If they ask you in the exam which of the following is a pre-systolic heart sound, then the primary answer to be remembered by you is S4. So the sequence of events should be very clear, what comes first and what comes later. Like for example, in the exam, if they ask you what comes after opening snap or what comes before opening snap, you should not really have to struggle, but you should be able to answer it spot on. Also, you should be able to tell data which I'll state before you, like if they ask you regarding loud opening snap, then loud opening snap implies that the mitral valve and tricuspid valve are opening with force, and this usually happens in a valvular condition by the name of mitral stenosis. So if the question is asked simply as loud opening snap is seen in, that would be mitral stenosis. One of the additions that I'll be making in this particular representation will be for a benign tumor of the heart. This benign tumor of the heart is known as atrial myxoma. In this atrial myxoma, you will be able to hear auscultatory funding, which is by the name of tumor plug sound. If you look at the diagrammatic representation, you can see that normal 130 ml blood is able to enter into the right side of the heart of the patient when it comes to normal. But if a patient is having a tumor, which is by the name of atrial myxoma in the left atria, this tumor is a pedunculated tumor. The tumor has a stalk. By this stalk, it is able to float in the lumen of the left atrium. When the blood will enter into the left atria of the patient, the blood will hit the tumor. Depending on the size of the tumor, the amount of blood going in the left ventricle of the patient will be relatively lesser. And you can also see the fact that this tumor will swing in a downward direction like a pendulum. Because of the flow of blood, when it hits the tumor will swing down like a pendulum, and this tumor will go and hit the mitral valve leaflets. The sound which is produced by the tumor going downwards and hitting the mitral valve leaflet is the one that is technically represented as the tumor plop sound. So tumor plop sound is the auscultatory finding in patients of atrial myxoma. Now let me hypothetically increase the size of the tumor. This tumor can become as big as a golf ball in the lumen of the left atrium. When the tumor will become as big as a golf ball, you can see that it will be causing significant obstruction to the entry of blood into the mitral valve. Therefore, a question that has been asked in the exam said that atrial myxoma will behave like which valvular lesion. You can see that the tumor is causing physical obstruction of the mitral valve. So, because it is causing physical supravalvular obstruction of the mitral valve, I can just say that atrial myxoma will behave like mitral stenosis. Therefore, mostly the complaints that will be seen in these patients will be that of low cardiac output. These symptoms will progressively increase proportional to the size of the tumor. And when I use a metaphor golf ball, the tumor can really be as big as a golf ball, totally occluding the lumen of the left atria primarily. In all of these patients, the intensity of tumor plop sound will increase as the size of the tumor will increase. So, if the tumor is small, you have a very faint tumor plop sound that might not be auscultated, but later on when the tumor will become bigger, the tumor plop sound definitely will be auscultated, and tumor plop sound will also be a diastolic finding, because you can see that the following diagram is that of diastole. So there is free flow blood occurring in the ventricles of the patient. So this is primarily a diastolic sound. I have also represented this tumor plop sound. The tumor plop sound will be heard at the time of the diastole. The tumor plop sound will be heard petic rose and corresponding to the opening snap. So I made a small addition there. Therefore, in the exam, remember the tumor plop sound is a low pitch heart sound that is heard very close to the opening snap. I drew it after the opening snap because opening snap is the time when mitral and tricuspid valve will open. And after that, the tumor will go and slam against the mitral valve, resulting in generation of a tumor plop sound. If we look at the symptoms of these patients, the reason why most patients of atrial myxoma will come over to you will be because of the following complaints. Most of these patients will be having complaints of effort intolerance. This effort intolerance is primarily because of low cardiac output. Less blood comes in, less goes out of the heart of the patient. So the low cardiac output of the patient will explain effort intolerance. However, as time progresses, the tumor will become bigger. Then this tumor will start causing obstruction to the flow of blood in a forward direction from LA to LV, and therefore there will be congestion in the left atria. If there will be congestion in the left atria, it will result in congestion in the pulmonary veins, and congestion in the pulmonary veins will result in generation of pulmonary edema of the patient. Therefore, the next complaint that will be seen in these patients will be that of development of difficulty in breathing. And this difficulty of breathing will keep on increasing the bigger the tumor will become. More bigger tumor, more physical obstruction, more pulmonary edema will cause difficulty in breathing. Now I want you to mentally visualize that this patient is sitting on a chair next to you. Because of gravity, the tumor will go in a downward direction and will cause physical obstruction of this orifice. Therefore, when this patient will be in a sitting position like you are at the moment while you are listening to this lecture, because the tumor will be causing physical obstruction, it will worsen the congestion in the left atria, congestion in the pulmonary vein, and congestion in the lungs of the patient. So the difficulty in breathing in this patient will increase, especially on sitting position. If this patient will go in a supine position, then the tumor will be displaced from its original position and the difficulty in breathing will reduce. Therefore, the term which was asked in this time's December MCI as well as in the previous June MCI 2015 was platypnea. Platypnea basically means that the patient is having difficulty in breathing in sitting position. Please do not mix this with a terminology by the name of orthopnea. Orthopnea as a term is seen in patients of congestive heart failure, and orthopnea is characterized by development of difficulty in breathing on supine position. So whenever you are asked regarding orthopnea, that would be difficulty in breathing on supine position, but platypnea basically means difficulty in breathing is in sitting position. Also, do not mix this with an alternative terminology by the name of trypopnea. Trypopnea would mean that the patient is having difficulty in breathing, but this difficulty in breathing would be seen in lateral decubitus position. Difficulty in breathing on lateral decubitus position is referred to as trypopnea. Orthopnea would be in supine position. Patient will feel better on sitting up. But in the exam, they asked you regarding a term by the name of platypnea. Platypnea would mean like you are sitting at the moment, patient is breathless, he lies down, he rather feels better. This is a feature or a hallmark feature for atrial myxoma. So whenever you want to read the term platypnea, it always implies difficulty in breathing in sitting. One of the features, it is one of the diagnostic features for atrial myxoma. Obviously, as we progress in the class, I will be telling you other causes of platypnea also. But at the moment, one to be remembered is the topic of interest, atrial myxoma. Coming back to the symptoms, this condition is usually more common in young females. So the MCQ will begin by saying the fact that the patient is a young female. The question might even mention that she has elevated ESR. She complains of fatigue and tiredness in the form of effort intolerance, difficulty in breathing on sitting position, that would be platypnea. She can also have development of syncope, and this syncope would again be related to position. When I say positional syncope for the patient, I mean the fact that when this patient is sitting, because this tumor can cause almost a complete obstruction of the mitral valve orifice, therefore the cardiac output can become significantly less, resulting in syncope. Whereas when this patient will change position from a sitting to a supine position, then the tumor will be displaced and therefore blood will be able to flow from LA to LV and the symptoms will reduce. Now when this patient comes to me, when I am going to auscultate her, on auscultation, I will be able to hear a auscultatory finding which I have already explained to you, tumor plug sound, which will be a low pitch heart sound. And because of the fact that it is a low pitch heart sounds are always heard with the help of a bell. So I will be able to hear a tumor plug sound in this patient whose intensity will increase with the size of the tumor. If I am asked regarding the investigation of choice for this condition, then the investigation of choice for these patients can be a transthoracic echocardiography. Though if the tumor is small and is not visualized, we can also do a transesophageal echocardiography, but initially most of these tumors can be picked up on transthoracic, if not then transesophageal echocardiography. The treatment of choice for management of these patients would be surgical resection. Obviously, medicines is not going to work for this particular case. Though there can be recurrence of the tumor, the percentage of recurrence is very, very less. But I have explained this topic here before you because I wanted to explain a simple heart sound by the name of tumor plug sound. The topic that we are going to discuss is still the heart sounds, but I will be making an addition now. This time I will be explaining to you an auscultatory condition, an auscultatory term by the name of pericardial shudder. So let's have a look at what we mean by the word pericardial shudder. I will be discussing regarding a patient who is having extrapulmonary TB, tubercular pericarditis. When it comes to tubercular pericarditis, because it is extrapulmonary TB, if you have to diagnose extrapulmonary TB, obviously a chest X-ray is always going to fail you because extrapulmonary TB cannot be diagnosed on basis of X-ray. You cannot diagnose extrapulmonary TB with the help of Mantoux test. Mantoux test will most of the time be false negative in patients of extrapulmonary TB. ESR is never a diagnostic test. So one, you should be knowing that what is the best test for extrapulmonary TB, that is for tubercular pericarditis. If we had a effusion, we could have done a pericardiocentesis, remove the fluid, check for acid-fast bacteria. But overall, if the MCQ is simply saying best test for extrapulmonary TB, then the answer in the MCQ should be given as a term by the name of gold quantiferon, which is one of the best tests for diagnosis of extrapulmonary TB. Now for this patient tubercular pericarditis, the treatment part would be giving anti-tubercular treatment to the patient. For extrapulmonary TB, under the DOTS program, ATT should be given for 6 months only. It is not 9 months, it is not 12 months, as most people tend to answer, it is 6 months. In the revised DOTS program, for extrapulmonary TB, even if it is tubercular pericarditis, ATT is for 6 months. When I will give this ATT to the patient will definitely feel better, his chest pain will go away, his fever will gradually start reducing, his appetite will improve. So overall, there will be an improvement in the condition of the patient. But at the same time, he might say, doctor, oh, I don't feel very well. He might say, doctor, I feel a little breathlessness and I might neglect his findings. What basically happens in most patients who are suffering from this medical condition of taking ATT for tubercular pericarditis, there can be a gradual onset, development of a thick zone of calcification. There can be a development of gradual onset, thick zone of calcification outside the pericardium of these patients. Therefore, I have now shown the heart encased by a thick zone of calcification in patients of constrictive pericarditis. If you compare this with a normal heart, if this is the representation of the left ventricle for you and me versus a patient who's having calcification outside the heart, the red here is representing calcification. The red here is representing an encasement outside the heart. The lesion is referred to as constrictive pericarditis. If you compare the filling of blood in the heart of a normal person versus the heart of this person of constrictive pericarditis, there are some hemodynamic differences. 130 ml is the amount of blood that enters into our ventricles when you or me are relaxing at the moment. When this blood will come and hit the wall, 130 ml is sufficient volume. When this blood will come and hit the wall, it will cause a minimal distension of the wall of the heart in you and me. So when it comes to patients who are having a normal heart, 130 ml blood will take some space and will cause little bit of distension of the wall. However, in this patient of constrictive pericarditis, number one, I am showing relatively less blood will be entering in the heart of the patient because the heart is surrounded by a thick zone of calcification. Second, when this blood will come and hit the wall, it will try to stretch the wall but will fail miserably because you can see a thick zone of calcification surrounding the heart of the patient. So the blood will come and hit the wall and bounce off, hit the wall, bounce off, and therefore in this patient, because this patient is having a non-compliant ventricle, I am calling it a non-compliant ventricle because there is a thick zone of calcification. The blood will hit the wall, bounce off, and it will release and will cause turbulence in the ventricular chamber. If you compare with a normal heart versus this person's heart, you can see that because the blood is coming and hitting the wall and there is a non-compliant ventricle, the blood bounces off, resulting in development of an auscultatory funding, and this auscultatory funding is the one that is of interest to us and is known as pericardial shudder. For some weird reason, most books refer to pericardial shudder as pericardial knock or refer to this as pericardial shock. The basic point is whether you call it a pericardial shudder, whether you call it a knock, or whether you call it a shock, all three imply the same, and this will also be a diastolic finding because this particular diagram is representing diastole. Therefore, I am going to superimpose this also in that particular diagram that I made on the contralateral board, where I will be showing the pericardial shudder position. However, instead of simply putting it, let's go into logic. The logic would be like this: mitral valves will open. This is representing mitral valve opening. Mitral valve opening is opening snap. In a normal person, first mitral valve will open, then blood will go inside and hit the wall. Here also I am saying the same thing. First mitral valve will open, then blood will go inside the heart, it will hit the wall and will bounce off. Therefore, in this particular patient, I can say the fact that first opening snap will happen, then blood will go inside, hit the wall and bounce off, resulting in development of a auscultatory funding, and this auscultatory funding which I am now representing before you is the one that is known as pericardial shudder. Pericardial shudder is heard at the same time as that of S3. Pericardial shudder is heard at the same time as that of S3 because of the fact that first mitral valve will open. Opening of mitral valve is opening snap, and after that the blood will hit the wall and it will bounce off. So basically pericardial shudder will be heard after the opening snap. I have therefore represented in this diagram before you the following cardiac events which you need to remember for the exam. That is, heart sound after S1 is ejection click, after S2 is opening snap. You should be able to tell data with respect to what comes first and what comes later.